For those of you who don't know me, I'm Chris Beyrer. I direct the Duke Global Health Institute. Delighted to be here with my colleagues today, folks who worked with over many years. I'm going to introduce the panelists in a moment, but I do have just a few housekeeping things to say. First of all, we also do have an online audience today, so I want to give a shout out to all those folks. Welcome. And we do have somebody monitoring the chat, so there's a Q&A function there. And Sean, one of our recent graduates who just finished defending his master's in global health, yay. That's an awesome moment. And so he'll be monitoring if there are online questions. We will hopefully have enough time where each of the panelists will speak. I'm going to do a brief introduction. And then hopefully we will also have both from the folks online. Sure. So before I do my brief introduction, I do want to just introduce the panelists. So we can go in order. Tom McHale, who is sitting to my right, is with Physicians for Human Rights. And if you don't know, Physicians for Human Rights is one of the leading advocacy organizations in advocating around the right to health, a Nobel Prize recipient organization. And Tom is Associate Director for the Health and Human Rights Program at DGHI. He documents health-related rights violations, and he has really worked in some of the toughest places there are. He's done this work in conflict zones in the Democratic Republic of Congo, in Iraq, and recently in Ukraine. So he really does know. Seated next to him is the wonderful science writer, journalist, activist, Emily Bass. For those of you who haven't read it, this is really the definitive book on the PEPFAR program, To End a Plague. It was published in 2021. It's a wonderful read, and importantly now, as we're going to talk about today, all the changes that affected the PEPFAR program, this book is going to remain as a critically important testament of the program really at its height. So Emily and I have been friends and colleagues for 25 years or so. She has played a number of important roles, recently working as an advisor to the last ambassador of the PEPFAR program. She's been working on the project you're going to hear about today on South Africa, in particular with Physicians for Human Rights. She won the 2025 Emerging Crisis Award for her work documenting these impacts. And as I said, she's the author of that. Last, we actually have a card-carrying human rights lawyer. That's very important. We're going to talk about human rights. None of the rest of us are lawyers. Nina Sun, who is a colleague, she is a lawyer and human rights activist. She does global health law. It's a very particular part of the law. She's been doing this for more than a decade, worked as a technical and strategic advisor for UNAIDS, the WHO, and really focusing on that intersection of legal framework and equitable health. A relatively recent move to the Triangle area. So what we're going to talk about today is about health equity and health access, and in particular, what has happened since January 20th, 2025. So a little over a year now ago, that on the very first day of the second presidency, the president put an immediate call to all humanitarian assistance. That has never happened before. And it's extremely important to understand that when that happened, the U.S. was by far the largest supporter of health and humanitarian assistance globally. And rather dangerously, other donors have been stepping away from funding and support for global health and for health-related humanitarian assistance for their own reasons. But we were concerned, the people who worry about this were concerned that really leading up until 2024, there was a smaller and smaller contribution from other countries, and the U.S. was really standing alone with dominant player in overseas humanitarian assistance. So that abrupt halt calling this event after the Halt, Health and Human Rights Implications of Foreign Aid Cuts, had a disproportionate involvement. You're going to hear some real experts on it. There is a particular focus today on South Africa. And the reason for that, and the reason why PHR has done recent work in South Africa and will be putting out a report, should be out in
21st of April.
21st of April, so stay tuned, is because South Africa has not just had a cessation of foreign assistance, and as you'll see from the numbers I'll show you, was a major recipient of substantial assistance, but also for political reasons that are complex, we can talk about it if you're interested, also had an abrupt cessation on all research funding. And South Africa was a major research partner in HIV, but also in tuberculosis and a number of other really important diseases. And just to give one example only, this is a question for the students in the room. What was the most important preventive innovation in HIV in the last several years? Anybody know?
PrEP.
PrEP, did I hear? Lenacapavir. Somebody said lenacapavir. Okay, so a twice yearly injection, a Q6-month infection, that in a very large clinical trial showed 100% efficacy in protecting cisgender women. That's the first time we ever had a prevention tool that was better in women than in men. And that really is a sea change. So there were 28 trial sites for that trial, the phase 3 efficacy trial. 25 of them were in South Africa. And virtually all the endpoints that gave us an answer for that study were in South Africa. So the reason that American women are going to have access to this prevention tool is because South African women stood up and volunteered. That's incredibly important. So slides, please. My slides. Oh, I have to click. There you go. Okay. So very briefly, this is through the end of 2023. And what you can see there, that very large kind of navy blue slice, 42% of all health assistance was from the United States. The next biggest donor is the UK at 12%. That has been declining ever since Brexit. And then you can see there's Germany, Japan, France, the Nordics, a few others, but really were providing the lion's share. However, very important to keep in mind, that is a rounding error in the US budget. It is less than 1/100th of the federal budget. So that tiny little slice is what we're looking at. And in fact, cutting all overseas development assistance essentially is budget for the US. You can see here, this is for a number of years of funding, that through the end of 2024, global health funding was about 12 billion, 12.5 billion. That is a lot of money. Those two green spikes where there's additional money in 2015, that's the West African Ebola outbreak. And then what is that big spike in 2020, 2021? So yeah, there have been increases, but as you can see, basically it's sustained high level funding. Now, it was not evenly distributed. So almost half of all of those dollars are HIV dollars. That's kind of incredible. And that is because of PEPFAR, President's Emergency Plan for AIDS Relief, that you're going to hear a lot more about. The next biggest is our contribution to the Global Fund, which is also HIV, but also TB and malaria. Then maternal child health, global health security and malaria, TB, and virtually everything else. Tiny little slices for orphans and vulnerable children and for neglected tropical diseases, a small amount of money in nutrition. HIV is getting the lion's share. This is the countries and the distribution, and you can see, of course, Sub-Saharan Africa lighting up bright orange there, very heavy recipient. If you just look at the 10 biggest recipient countries, all of them are in Sub-Saharan Africa, and just take a moment to look at the numbers there. Okay, Nigeria was getting $560 million in health assistance. That's money. And South Africa was the fourth biggest recipient, 490 million. And then some small countries like Malawi, a very impoverished small country with a bad HIV epidemic, $250 million a year. So you can imagine what an abrupt cessation of that level of health funding can do to a country like that. Okay, global health funding by region, you can see 85% of it is sub-Saharan. So that is, again, PEPFAR, that is HIV funding, and the rest of the world is really getting about 15% in total. So major changes. This is from a Nature Communications early paper, people saying things like it's chaos, the way things are going. I feel like I've worked so much for nothing. And just to say, the PEPFAR program stepped in when Africa was in deep trouble and had this extraordinary investment, $110 billion, 25 million lives saved, 5 million or 5.5 million children born without HIV, and GDP capita recovery. Our group actually published one of the very first models out there, Gerard Radadosi and myself, and a modeler named Kai-Hoan Khan, about what the impact would be. About 100,000 deaths in the first year and 135,000 perinatal transmissions. This turned out to be conservative, but it's not far off what actually happened. Marco Rubio put forward a waiver. You're going to hear about that. The last thing I'll say, the reason that waiver did so little is because while PEPFAR was being saved and has been refunded, the implementing arm of PEPFAR was USAID, and this is what proportion of US global health funding was supported by AID, and you can see it's overwhelming across all these disease categories, the one exception being PEPFAR that also had money from the CDC. And then the very last thing, these are all the areas where there was grant terminations or no new grants allowed in the changes with the NIH. You'll recognize many of these things, but the very last one there is South Africa. No new grants or enrollments in clinical trials. And that has not changed. That is still where we are. So I'm going to stop there and let me just say one other thing, which is that if you are wondering why I seem to be smiling while I'm telling this dark, sad story, because my partner is here, Andy Lambert, who is there. And Andy worked with Emily Bass and PHR on the work you're going to hear about from Sundown. So I think next up is, oh,
No, that's right.
okay.
Thanks so much, Chris, and thanks everyone for joining us. I am going to set the stage for South Africa and the data that Emily will talk about in a few minutes. But first, who am I? Why am I talking about this? So I work at Physicians for Human Rights, and we're an international human rights organization that works at the intersection of science, medicine, public health, and the law to document human rights violations using a fact-based approach so that we're bringing data and science into conversations about some of the most difficult challenges facing us in the United States and around the world. For that work, PHR, as Chris said, shared in the 1997 Nobel Peace Prize for our work on the campaign to ban landmines. A lot of that work actually started with research that PHR did in Cambodia to look at the impact of landmines on people in Cambodia. And those data really led to a lot of advocacy impact. And following that model, we'll talk about how we've applied that approach to the foreign aid cuts. So in January 2025, when the US administration froze new foreign aid, issued stop work orders, halted awards, and caused, as Chris said, chaos. There was a really abrupt disruption of many already fragile health systems that were under already severe strains from, after COVID, under severe strains from a lot of the threats that we see around the world. And we were seeing severe disruption of public health services. Everyone in the global health world was saying, we're hearing impacts on provision of care, on service and support programs. And we put together kind of a body of work to really seek to document the impacts around the world with particular focus on sub-Saharan Africa. So we launched a project that really tried to look at the evolving impacts of the foreign aid cuts over time. This is the story of the foreign aid cuts is not one story, but actually many different stories pieced together to show the impact of US policy decisions. For our work, we really started in January 2025 and then did a series of data collection projects that really looked at the impacts that have evolved in different areas, but also as US policy has shifted. The first kind of documentation project started in April. Within that first 60 days, looking at the impacts in Tanzania and Uganda on HIV programs. PHR then worked where we have offices and programs looking at the impacts in Ethiopia, a country that has experienced a multi-year complex crisis that has featured up to 500,000 people dead and over 50,000 people, it's been estimated, experience conflict-related sexual violence. We worked in Kenya to understand the impacts there, and as well as the Democratic Republic of Congo, where we've been working for a long time, documenting the impacts of the conflict. In September, we collected data in South Africa, but at this whole time, we were still waiting for the US government to actually release data that it had collected and routinely published on PEPFAR and other global health indicators. We have not seen those data, and in December, PHR filed a Freedom of Information Act request, and then followed up in February 2026 to look deeper and really compel the release of those data. In March, just a few weeks ago, we confirmed the data that Emily will talk about in South Africa. And what we've seen is really complex disruption of healthcare services all over the world. In Tanzania and Uganda, we saw significant disruptions to HIV service delivery ecosystem, loss of peer cadres, impacts on individual healthcare making decisions. People reported to us that they were skipping doses, they were hoarding medications, that people were able to access healthcare because the Trump administration's policy shifted where PrEP was only for pregnant women. So then men who have sex with men, sex workers, and others who were accessing these services were no longer able to access services. We heard similar stories in Ethiopia where including severe disruptions to maternal and child health services in places that have experienced conflict. One partner told us that women died because of USAID supported structures had to close because of these stop work orders. In the Democratic Republic of Congo, we heard similar but different things. And I want you to really pay attention to how the story is slightly different because the aid that the US was providing in each place was a little different and meant for different things. One of the most disturbing things that we heard out of the Democratic Republic of Congo was that in this context where conflict-related sexual violence, which is an area of my expertise, has been very prevalent, survivors of sexual violence have not been routinely able to access post-exposure prophylaxis to prevent HIV, pregnancy, and other important post-rape care tools that come in from these inputs that USAID supported. In Kenya, we saw widespread stockouts of healthcare inputs. We heard of extreme pressure on the healthcare workforce. And we've seen and heard that areas of public health where decades of advocacy have gone into strengthening have now just been collapsed into single services. Services for sexual violence, for TB, for malaria, for HIV. It's all one line at the facility. So we've seen these disruptions across the world, really undermining continuity of care, access to essential services, and it's really triggered erosion of access for key and vulnerable populations, particularly around HIV, sexual reproductive health, and gender-based violence. These services that were developed for these specific populations now are being mainstreamed because governments have to focus on service delivery into more generalized services. This is a real concerning trend because we fought for so long to really shift and better and use the science to really show us where to go. We've developed a lot of recommendations, and I think this is where we'll transition to talking about advocacy. We've documented up until, what Emily will then talk about is what's happening now in South Africa. But our documentation is really meant to push for change. So we take these recommendations and we have a three-pronged advocacy approach. We want to make sure that fact-based knowledge is actually driving policy decisions, not opinion, not ideas, but facts. So first we shape public opinion. Where did we lose that? I'll leave that. Public opinion. We've shared these findings widely in media. We've shared them in newspapers like El País in Spain, National Public Radio, The Guardian, The Independent, really to make sure that the public understands the impact of these foreign aid cuts, and that we're able to then use that to shape the public conversation. This isn't just something that's happening far away. It's actually something that's happening because of US policy shifts. We also want to make sure that policymakers have access to data and are using data to inform the conversation, so that we've been able to present these data with members of the House of Representatives, Senate staffers, and at the United Nations to really make sure that these data are used to inform concrete conversations around what's next. And the third, in that we'll preview a little bit, what Nina will talk about is also shaping legal arguments. We don't just want the data just to sit aside, but actually we're collecting data to inform amicus briefs for court cases that really show the impact of the foreign aid cuts. But the story has been shifting over time. And what we're seeing now is a little bit different impacts from the immediate impacts that we had seen in the first 6 months to a year. And I will shift to Emily, who can talk about what we're seeing now and give a preview of our forthcoming research in South Africa.
Great, thanks so much, Tom. Really, really excited to be here. I guess since we get to shout out our loved ones. My older son Sebastian is over there. That's delightful. We are descended from Tar Heels, the ancestors. So I also have to say that. Sorry, I probably, something bad might happen while I spoke if I didn't do a little Carolina Blue. So I also want to situate us where we are right now, because it's confusing. It's intentionally confusing. Okay. So USA got destroyed. PEPFAR did not get destroyed. We actually see that bar graph differently. So CDC had less than half of the funding for PEPFAR, but was responsible for almost 2/3 of the antiretroviral treatment delivered and 2/3 of the tests. CDC did not go into the wood chipper. Okay, CDC, they had a temporary restraining order in late February that allowed them to continue all of their programs. So as somebody who I wrote the book, I was really happily moving on, I'm writing a different book. I spent the first part of the year realizing that I'd been sucked back into this story, trying to make the case, trying to call attention to the fact that PEPFAR was not gone. We had something to salvage, right? That it's different from what's been destroyed. PEPFAR is an interagency program, Department of Defense, now Department of War, CDC, USAID, and it was still there. And it is still there. So while I can't quite make the same argument that I was making in the first 100 days when I was in Tanzania and Uganda, doing our first report, and I want you to know this because you are the practitioners, and this is going to be the world you're shaping and influencing and engaging with, that the US last year was destruction, and now there's a strange new world being created. And so we're really sort of talking both about the impact and what's could come out of the wreckage. March 31st, today, okay, is the expiry date for the bridge plan, which was a 6-month infusion of funding to PEPFAR programs to continue operating while new funding was put in place through the America First Global Health Strategy, which I will say once and exactly once, because you can't make me keep saying that. But there's supposed to be memorandum of understanding and money flowing starting tomorrow. Guess what? They missed the deadline. You know what? It's hard to create giant new multi-disease area funding mechanisms. Andy could have done it, right? So they missed the deadline. So the PEPFAR funded programs, which is this limited set of services that PEPFAR used to supply, are now extended for another 3 months. The permission to continue operating came with no new money. So as of now, CDC and DoD programs are the permission is to use your pipeline. It's to use money that you have in reserves. Most of these programs have 3 months in reserve. They don't have 6 months in all cases. The thing to know, and don't worry, I'm going to talk about where we are, but I want to give people a sense that there are things to win. There are things to still keep fighting for. Terrible things have happened, but we are still in a game. Might be the Hunger Games, but we're still in a game, okay? So PEPFAR is unique across all of foreign aid and across all of global health aid because it's put into the State Department by its architects, these West Wing operatives who go, USAID can't run it, and CDC would think they were the World Health Organization. We have to put it somewhere. We're going to put it in the State Department, but it's a true interagency program. It's now in a State Department that is eliminating the interagency. So CDC is being strangled of funding. That's why it's more run on pipeline, DoD. But it's not over. So that's what I wanted. Before I get into everything that we found, I just want to, March 31st, bridge plan is over. People are still trying to do the best that they can. And that's really a theme across all of this work that we've done. So like the Uganda, Tanzania report that I collaborated on with PHR, this is an oral history-based project. It had a little bit of an impetus from in those very early days in February. I'm on a lot of WhatsApp chats with media and activists, and everyone's going, well, can somebody find me someone with a dead baby? Right. And it's like, the media, like I have a crew and I'm arriving and I need to find a transgender person who's about to die of AIDS. But, if you stop your treatment and you were virologically suppressed, nobody should be dying on January 24th. Right. But this sort of desire to find the worst possible outcome. And really what we have found is if you ask people what actually happened, it's horrifying and it's terrible and it's so multi-layered. And so that was part of the impulse, really. You'll read all of that, or we can share the slides. There's some of the narrators. So this is Cape Town, a young woman who's an HIV prevention activist, and that's the dapivirine ring, which is a vaginal ARB-loaded ring. And that below is a completely empty research site in the middle of a workday where the data collectors used to sit. There's my South African narrators, one of them in Johannesburg. So overall, and this is September. So this is almost a year later and then verified this month as we're finalizing the reports. In a country where the US paid for only about 18% of the overall HIV budget. And so sometimes people go, South Africa's an exception. It's got a high GNI. They should be paying for everything. There's lots of different ways to make South Africa an exception. But the story here is really always, in each of these countries, is what happened, what was the US paying for if it's 18% of the overall, but it's 100% of a service that nobody else was covering, and it disappears overnight. Very different from saying, in 2 or 3 years, you need to take this over. Overnight, right? That's not how you run public health. So we've seen disruptions in health service delivery, collapse of primary prevention in a country where adolescent girls and young women are 10% of the population, 25% of new HIV infection, 1,000 adolescent girls and young women per week are getting HIV. We have not bent the curve of incidence in AGYW or in key populations. And we have not yet found a PrEP strategy. We had not yet found one that was completely protective and easy for them to take. Not here. December 2024. I mean, it's right when all of this turns.
Yeah.
Is when we get this. So I'm gonna just let them speak a little bit. Ooh. This is a prep. These are all from our oral history. So this is a young woman who was both a prep educator, HIV educator, and on prep herself. She had stopped and she went back to the clinics. I want to start taking my prep again. And she basically tells the story. She walked in and she had to walk the nurse who was seeing her through the testing regimen that she knew she needed. And the nurse said, you know, but we wouldn't even do it. Now you're asking me to test you. If you didn't ask, I wasn't going to test you. So somebody who's prep literate, who's a prep educator, is trying to get her own prep restarted and witnessing a health system that is not equipped to meet her needs, right? She was there from 7 a.m. until 4 p.m. Let me tell you something. People don't do that for preventive medicine. They'll do it for treatment. Sometimes you're not going to do it for prevention. This is another same empty building. The wall says your future starts here. Loss of testing in the community, the same thing. If you want to get an HIV test in South Africa, and if you want to get your PrEP, it's still probably on the shelves, but you will have to wait the whole day to get tested in a facility that vans are no longer around. So the US is paying for these services that don't fit into a traditional government health system. And you can make arguments about whether those services should or shouldn't exist, but I would argue what you cannot do is stop them overnight without a plan. Okay, so this is the great thing about doing this oral history project versus being media is we have a tailored form, a release form, where the narrators can choose what will travel forward with their interview. And so it's very clear to them that they're not going to be identified. And so we were able to speak to government employed health workers who would not otherwise speak. And this is also because we had close South African collaborators. So this nurse is describing overtaxed healthcare. She works in a clinic where 9 health workers were, at work on Friday. They weren't there on Monday. So what's everybody else is covering for everybody? So now you have a nursing sister who's busy putting a drip on a dehydrated child. And I've come in for prep and I'm sitting there for hours and she's correct to be hanging the drip on the child, but I'm not waiting. Person's already recruited for prep, but the patient leaves because he's tired of waiting. This one, what you see on one side is the sign that was put on the door of one of the men's health clinics in Cape Town. This is a man that I've spoken to for 3 hours, probably. He really went for the life story oral history, which is like one of the different, he really just went for it. I know, he was extraordinary. 2 hours and 45 minutes in, he says, I don't know if you can read it, it's bigger up there. He said, you know what, I didn't get my refill 3 weeks ago. I know I'm stupid. I feel terrible. I should have gone and picked up my drugs. But I just couldn't bring myself to do it. The government is doing the best they can, but they don't know your name. I don't want to go there. Right. And I think we also have to think, really, even though there's no compassion and no humanity in the government rhetoric at this moment, we are not just trying to provide bare minimum, lowest common denominator healthcare. Everybody deserves affordable, accessible, acceptable quality healthcare. He hadn't gone and gotten his meds, right? Took him 2.5 hours to explain to me to get to this thing. This is another government employee. The system is falling apart. The data backlog is enormous. Full disclosure, those are Ugandan files from my first trip because the government nurses were so nice about talking to me, but so freaked out about talking to me that I didn't want to photograph their photos. But trust me, it looks the same, right? These are paper files. They haven't been entered. And the nurses are saying, look, we know that there are people who we think are lost to follow-up who are actually in care. But we also know there are people who are newly diagnosed who never started. And we have no idea because they're not even entered. Okay. This is one of the people who was nice enough to talk to me, but I didn't take any pictures. We know people with HIV are staying away because of the long wait times. No one's calling them. No one's saying, hey, you didn't come back for your clinic appointment. We can't see that they're not coming. or what the story is. Can you imagine you're the data quality officer and you know you can't see it? We're waiting for a big bomb to go off in our faces. The other piece that's really important to understand, I think, especially as you may or may not encounter people going, why do we need to invest in South Africa? You know, they could take over, is that we weren't just paying for things for South Africa. We were investing in research infrastructure and trial infrastructure that was serving the US. We have the highest rates of TB that we've had in decades, and they're climbing. Do you know where you do HIV, TB co-infection research, TB vaccine research, develop new TB diagnostics? In South Africa. Okay. So, and while that's HIV money that we're talking about, that HIV money built the lab infrastructure that pivoted to do COVID-19 diagnosis. So yes, it's HIV money, but we had been doing all sorts of things. The people in the countries where we've been working have been doing all sorts of things. So this is another, and this last one, this woman saying, who's a research site staff member, the worst part is I'm currently recruiting for a study that requires research assistants and nobody's there. So she goes to the clinic to try to pick up, you know, counselors who are doing screening, who are doing recruitments. Nobody's there. So we have overnight collapsed a research infrastructure, and we are the litany of reasons that USAID was shuttered is waste, fraud, and abuse. We hear that all over and over again. There is nothing more wasteful than what has happened. Nothing more wasteful. And frankly, nothing more offensive, right? To humans, to healthcare infrastructure. And so it's both dire. I think, pretty sure that's my last slide. Okay, so yes, as waste. But seriously, I mean, we can still, you know, so right now, this week, there's been a huge groundswell to get the State Department to send more money to the CDC for the extended bridge plan. And we're winning. It's still possible. It's still possible to name and shame. Congress still cares about PEPFAR. So, you know, we are fighting a different battle than I wanted to, really, truly, a year ago when I started this documentation, but there's still things we can fight for and win. Grandma cannot read you those recommendations from here. My son probably can't come over there, but they are in HR reports, yeah. And it is, don't give up. Here are my recommendations. Do not give up. And let's do the right thing. Thank you so much.
Okay, thanks so much, Emily. Hi, good afternoon, everyone. And can I just say, I love the structure of this panel because I feel like the flow is just great. So as Chris mentioned, I'm a human rights lawyer, and I've been asked today to talk a bit about the human rights considerations of this catastrophic funding cuts that we're seeing. And first and foremost, I just want to say we are in a human rights crisis. We have been in a human rights crisis since January 24th, 20th, whatever the specific date was, 2025. And I wanted to take us back, though, to ask a fundamental question of why are we talking about this in human rights terms as opposed to public health or as opposed to epidemiology? You know, we opened the session with seeing like really stunning figures about drops in funding cuts, right? Why is that not sufficient? And it's not sufficient because framing the scenario that we currently live in as a human rights crisis visibilizes the people who are fundamentally impacted on a daily basis. And this is why I was so thrilled to go after Emily, because all of the stories that you and PHR colleagues have been collecting really demonstrates and showcases why it's so important to put humans front and center. We can use the data, we can use the information, and that is fundamentally important. But if we don't focus on the lived experiences of the people who can't access treatment, who can't access nutritional support to help them adhere to antiretroviral treatment, who can't access prevention measures when they know they're putting themselves at risk, or they don't even have an option and they are at risk because of the situations that they're in, that hits fundamentally different than looking at very, I would say, important, but quite cold, quantitative measures. So you need both. But kind of beyond this rhetorical use of the human rights framing, it's also important because, when we're up here and recounting to you what's been happening in all different countries, recounting to you the stories that Emily has found. It's not our opinion that it's morally wrong. It's not just based on, public opinion or public opinion polls of something is right or wrong. When we talk about this scenario as a human rights crisis, what we're talking about is a violation of fundamental existing legal norms and standards that have been in existence since World War II. So that brings us to the next question, which is, well, what are human rights? And I think, the phrase human rights gets kind of bandied around. It can be really colloquial. But what I want to underscore today is that human rights is actually a body of law. And it emerged out of World War II, and it's legally enshrined in a series of treaties. So these treaties protect civil, political, economic, social, and cultural rights. And two of the rights that I want to highlight today come from two of these treaties that are together known as the International Bill of Rights. And that's the Covenant on Civil and Political Rights and the Covenant on Economic, Social, and Cultural Rights. So the Covenant on Civil and Political Rights enshrines what's known as the right to life. It's pretty straightforward. Governments have an obligation to take actions to avoid preventable deaths. And the United States, along with 174 other countries globally, have ratified this convention. And what that means is that there is a legally binding obligation on all of these countries to protect the right to life. And when we talked about the right to health, that is enshrined in Article 12 of the Covenant on Economic, Social, and Cultural Rights, or the CESCR. And what that obligates governments to do is make sure that there are essential medicines, vaccines, diagnostics, as well as equitable access to services for all of the people within its jurisdiction. And also the committee that's in charge with monitoring how governments, how well or not well they are complying with their treaty obligations. The Committee on Economic, Social, and Cultural Rights, a real mouthful, has said that states, both individually and through international cooperation, are required to support the realization of the right to health. And I'd like to say, from a legal perspective, the United States unfortunately has not ratified the CESCR, but it has signed it, which means it is legally bound to not take actions that directly go in opposition of the treaty obligations. So I think the real question is, how do we start resolving this human rights crisis that we're in, right? So we've heard from PHR colleagues about the documentation, about the lost follow-up, about the complete collapse in services. How do we start to remedy this? So I propose kind of two ways forward. First is an underscoring of international assistance and cooperation, both because it is legally required under certain treaties like the CESCR, the Convention on the Rights of the Child, and the Convention on the Rights of Persons with Disabilities. So it is a legal obligation, but also because we live in a globalized world now. We just heard about research that allows Americans to access groundbreaking HIV prevention because of work done in South Africa. We live in an interconnected world, so whatever solution we have has to be done together. So what does that actually mean concretely? So for donors, there are still countries and private foundations that are still providing money for global health and development. So where those donors can continue that funding, it needs to continue. And it not only needs to continue to fund government institutions and services, but very importantly, it should fund civil society organizations and community-led organizations, because those, in addition to treatment, in addition to government services, those are the ones that really support the right to health, the right to life, and the overall enjoyment of human rights for various communities. And then there's another emphasis on multilateral and regional institutions. So where governments have kind of had a lack of expertise because of this funding drop off, it's incredibly important to have multilateral and regional institutions provide that kind of technical guidance. So how do they move forward in light of this steep funding cliff? How do they pivot services? Sometimes governments can do it on their own, but for a lot of low and middle income countries, relying on multilateral and regional institutions to both advance the implementation of the technical guidance and then facilitate processes and partnerships to really have countries work together is another way forward. And finally, I would say that, the domestic governments themselves that have been impacted by these funding cuts, in the first 6 months to a year after the funding cuts, it's going to be really hard for them. They have to make difficult decisions about what to prioritize and what to implement immediately. But with time, there's going to be more and more information about what resources are available and what communities need. And the onus is on those governments to truly craft a responsive health response, overall response that takes that information into consideration, but also remembers that they are legally obligated to uphold their human rights obligations to non-discrimination and ensure equity and access to services and goods. And finally, I think this is the real key question that you probably have for the lawyer on the panel, which is accountability and remedy. And so I wanted to bring up 2 scenarios for accountability and remedy that are extremely important in this situation. So the first, as a general prospect, domestic governments are responsible to protect, respect, and fulfill human rights. So the monitoring that PHR has done in terms of looking at how governments have responded, how community systems have responded, how communities are responding, that monitoring is essential as we look towards the future to understand whether governments are actually fulfilling the legal obligations that they've already agreed to in the treaties that I've just discussed. And finally, the question around US accountability, that is really complex and challenging because in general, laws only cover the countries and the actions that are within a specific jurisdiction. So a government is only responsible generally for the actions that happen within their own territory. And that makes it really complicated in this specific instance, because what we're talking about here is the US government and other donor governments whose actions at home have fundamentally disastrous consequences abroad. But I'm going to echo Emily's message to remain hopeful. And this is where I also love working in the law, because the law is not static. This is our opportunity to start pushing boundaries, to start saying our laws are currently inadequate to address the situations in which we find ourselves. And so we've gotten some novel theories and proposals for how to think about accountability. Like Chris wrote a brilliant piece in The Lancet that really highlights this doctrine of legitimate expectation in administrative law. So can we use contract law and administrative law to really hold third-party governments accountable? And then within human rights law, we've got this concept of territorial, extraterritorial application of certain human rights obligations. And those apply in very, very specific circumstances. And usually the previous case law has really focused on military occupation. But there's absolutely no reason why in certain circumstances, for instance, if you are funding 100% of a certain type of global health intervention in a country, or 90% of, let's say, HIV interventions in country X, if you immediately draw out, could you argue that country X has effective control? Could you argue that the third party country has effective control? We'll see. So this is why I'm saying, it can be really hard to look at the data that's being presented, to look at the stories that have been collected. But there's 2 points, if you go away from this session, that I hope that you remember. The first is we're at kind of an inflection point for all of the work that everyone has done, the documentation, the collecting of stories, making sure the US government is responding to its own domestic obligations of transparency. All of that is so important for future accountability. And all of you, whether you decide to go into medicine, global health, law, you all can have a role to play in shaping future accountability and in creating a better world where we never have to find ourselves in this situation again.
What a point to end on. So happily, we do have about 10 minutes for questions, and you're also looking online. So we'd love to open it up. And by the way, if any of you have questions for each other, please feel free. Okay, we have Obali in the back, so you're second.
Yeah, considering a worst case scenario was meaning the United States government decides to stay the way it is, and how do we see the response from other countries or community donors, and how do we see global health within like the next decade or so?
So maybe I'll just start by saying one thing is very important to understand, which is that, of course, we did not have a budget and we did not know what overseas development was going to look like until February. Like February 3rd, we had the finally congressional resolution. The overall envelope for global health is only a 6% reduction. It is not at all what the Trump administration asked for. The Congress is with us. And while the Constitution is still relevant in this country, Congress appropriates money. Right? The power of the purse is with the Congress. And by the way, it was on both sides of the aisle. We had very good support from Republicans and Democrats and a few independents. So PEPFAR funding, as Emily said, has continued, and the overseas development assistance, it's a modest decrease. It's all under this new Bureau of Global Health Security in the State Department. So it's under Secretary Rubio right now. So there are big changes, and it is all being implemented through the America First Global Health Strategy. But it's not like money isn't there. It's also a very short year. It's supposed to have a year, usually lasts 12 months, right? But this year started February 3rd and goes through September 30th. So it's a 7-month year to get all that money out the door. So it's not going to be easy, but nevertheless, just important to say.
I think the other thing I would add is that across everybody that I spoke to, and it's been I did 80 of the oral, I spoke to 80 different narrators and Spreading Oral History Project in several other countries. PHR did work that I wasn't involved in. Nobody wanted the HIV money to last forever. Nobody thought that the US government was going to fund this forever. They just wanted time, and they just wanted transition. And in fact, what I was doing in this sort of brief interval when I was a strategy advisor for PEPFAR, for the ambassador, prior the Biden administration appointed Ambassador John Nkengasong, was working on something called sustainability, which is basically what we now are doing, after having crashed the plane. But no, really, I mean, it's the dumbest way ever to do. It's the most wasteful and abusive. But and I'm sure folks here have had this experience in African countries, in your home countries. Nobody wants to do this again. Nobody wants to wake up one morning and be in this level of dependency and have the funding withdrawn. And so I think one of the things that's happening already is really interesting conversations about African sovereignty, about what more independence looks like. My concern about that, right, is that who is part of the sovereignty? And you raised civil society and impacted communities. In many, sovereignty has the word sovereign. It has king in it, right? Are the people in sovereignty? Because governments are not, regardless of what continent they're on, they're not by definition good actors. And in fact, sometimes they're bad actors. And so I think we're going to see a lot more nationalism and a lot more regional organizing. And I am concerned about the place of civil society and impacted communities in many countries where civic space is also shrinking. But that, I think, is the other thing we're gonna see.
Please.
Great, thanks so much for that, and I think to just add on to your last point, civic space is shrinking here as well.
Yeah.
Currently. So I want to take a step back, maybe to the health as a human right issue. I think that we haven't done a very good job of advocating for that here in the US, let alone globally. So if people in the US don't think health is a human right, then their support for funding outside of America is going to be a challenge. So I'd like you all to address what that looks like, how we can kind of bridge the advocacy gap, because it's a huge one. And then how does that fit into the global health security piece? So I heard Samantha Power, former head of USAID, a year and a half ago on her farewell speaking tour. And global health security was the one thing she thought that USAID had been working on that Trump was going to buy into. Well, clearly that hasn't happened. So I'm curious about how we work on that in terms of the advocacy piece. And then finally,
Two questions.
oh, okay, yeah.
Please.
Okay, so I think it's a really interesting question that you ask about this kind of disconnect between health as a human right that the global community has recognized. And as I mentioned, the US has not ratified the CESCR, it's only a signatory, right? And so there's definitely there's a domestic gap in terms of understanding, what the purpose of healthcare is and access to healthcare and whether it is a right. But honestly, when we talk about ODA, when we talk about foreign assistance, to me, those are separate issues. Like you can have a country that says, okay, we still are figuring out how we want to frame access to healthcare in our country. I mean, individually, I can believe it's a human right, but whether the country recognizes it in the Constitution, although there are states within the US that do recognize elements of health as a human right. I think that's a separate issue than understanding why it's important to fund global health and development projects abroad. And I say that because, there's the rhetorical and the kind of moral and legal normative standard that we would like to see. And then I think there's the practical element of saying, but if you don't fund global health work, like these are these very severe consequences that we see, not only for health abroad, but also for our health at home. So I think there's a multitude of different arguments that can be used to really be persuasive about why it is so important, not just to look at health issues, but also to look at development issues more broadly. And I absolutely agree with your point that civic space is shrinking everywhere. And we've seen this trend for a very long time over the past couple of years, even before the current administration came into office. Not necessarily in the US, but definitely abroad. And so all of these components, like, do we promote democracy? Do we promote openness, transparency, rule of law? Arguably, you could also argue that that is quite problematic in our own country at the moment, right? And so, to answer your first question, I just think it's important. It would be great to establish health as a human right and bridge that divide, but I don't think it's necessary to justify why it is so fundamentally important to invest in these interventions abroad as well.
And just to add on quickly, the aid cuts conversation is actually part of a broader conversation around the erosion of human rights in the United States and around the world.
Yeah.
We're not just talking about foreign aid cuts, we're also talking about armed conflict. We're also talking about a litany of other human rights abuses. And this is why documentation is so important, to really have a record of what happened and to use that fact-based record to really push policymakers who may be tracking many, many other crises at the same time to really understand the implications of these funding cuts and other crises in the abroad and in the United States.
I'm going to do 90 seconds on global health security. So there's something called the APS. Have you seen it? Oh my God.
Yes.
Okay, so it's an annual so Department of State is taking over the world. I talk really fast now. The whole global health world, right? And so they are giving out hundreds of millions of dollars in this instance, $290 million for global health security grants that are going to be reviewed by a merit review panel, which frankly I thought was what was going to decide whether my son got into college or not, but apparently is also, sorry, Debbie, a merit review panel where, wait for it, the interagency, the experts from CDC and DoD, which have dozens of biosecurity labs around the world, may be welcomed as non-voting members. Okay, so, and you know what happens? These are grants. Some of this is grants, not contracts. Grants is here, have the money, right? Enjoy. You know who it's going to? It's going to private sector companies with very little visibility. So I just want to be, and the words around it are okay, right? I'm going to do one more time. America First Global Health Strategy. You know, it sounds okay, but we got to keep pressing on it because every aspect of it is so cynical. It's not making us safer. It is not making us stronger. It is not making us more prosperous. If CDC and Department of Defense are sitting with, in the back row playing words with friends, while State Department people who don't have experience in this, and some of them do, but they don't in the kinds of things they say they're going to fund, are making these awards.
Do one last question.
Yes, sure, one question.
This is from Brianna. Much of our advocacy for global health in the last year has been framed within this America First language of how it makes us safer, stronger, and more prosperous. I'm wondering how or if the global rights argument, the human rights arguments in favor of sustained global health investment by the US fit within that framework. Have you witnessed our legislators respond positively to a human rights argument for global health? Or whether using that, the safer, stronger, prosperous kind of framing of America First, and kind of what's been the experience in terms of using that language to promote advocacy and change?
One really important thing to remember about advocacy is that you're tailoring your message to your audience and not necessarily that you're tailoring that argument for the audience. And different arguments will land differently with different populations. Emily and I feel similarly about the America First Global Health Strategy. There's a lot that needs to be added there. That's a framework that's in the United States right now. So that is something that we need to really work with. But at the same time, there were like sharp critiques of that strategy that I think is important. But I think when developing advocacy arguments, it's really thinking about who is your audience and what argument is going to land with that audience.
And just to say, look, we're spending billions of dollars still on health. And so I don't think there's going to be any penalty for poor performance, but there won't be a penalty for good performance. And if it's about markets and economic growth, that is okay. It does not, but before it was about compassion. And that's the one thing I'll say just in terms of the argument. The faith-based community needs to be brought back in, and they are coming back in, and they were the champions along with queer people and people with HIV and AIDS activists who together midwifed PEPFAR the first time, and the faith community is shocked and appalled at the lack of compassion in our programming, the lack of compassion for adolescent girls and young women, the fact that we've knocked out the age disaggregate. You know how many we have now? 2. 0 to 12 months and 12 months in everybody else. Okay? You cannot see if you are diagnosing babies. You cannot see the babies that are dying, 50% of them before their second birthday if they're not on HIV treatment. And so I think bringing the faith community in and saying, yeah, let's make it economically strong. Let's do it. But don't then give us programs, APS program statements that are flimsy and don't hold up to public health scrutiny.
And just to add to that, I think in terms of advocacy, absolutely agree that you have to tailor your messages to your audience. But, it's also important to keep in mind that there are strategies for the short term, and then there's the strategies for the medium term and the long term. And I think what we talk about in terms of immediate advocacy is who's in power now. What messages are going to resonate best with them? What language are they speaking? But it's important not to forget the broader goals that we as an international community, and the US is a part of that international community still, have agreed upon and aspire to. I mean, are there better ways we could do it? Absolutely. And so hopefully, you know, we don't lose that thread, that very important thread, as we kind of navigate through these choppy waters now.
Well, please, first of all, thank you all so much. Thanks to everybody for being here, online audience. But I'd like to ask everybody to join me in thanking these spectacular. I love your hopeful message. All three of you about documenting, using that data. You know, you're talking to a mostly global health student audience. You know, what you're studying, what you're learning, it really matters.
We've done it before.
We've done
We've done it before. We'll just do it again.
Do it better.
This time.